So, weaning process is one of the most challenging topics. That topic has been studied from 70s, 1970s, and 80s. And because in the worldwide, they have been studied for a while, but depends on the study design, depends on the patients. It's not really easy to compare the, the protocols. So actually, we don't have a big guideline. First of all, I'm going to start with weaning classification. So simple weaning is the patient on the ventilator who is able to extubate successfully on the first attempt. And those are the majority of the weaning patients. Actually, 70% of ventilator patients are in the category of simple weaning. The next one is difficult weaning. Those patients fail on the first attempt. However, up to three attempts or less than 7 days, they finally achieve to have successful expiration. And those are the 15% of ventilator patients. The last one is prolonged weaning patients. They failed at least 3 attempts for more than 7 days to discontinue ventilation from the first attempt. And they are 15. So those prolonged ventilation patients, like I said, is 15% of the whole ventilation, but actually the rate is increasing. The ventilator patients, more than 21 days, they have poor prognosis with 2-year mortality 25%. And more than half of prolonged weaning patients actually they could not succeed weaning in ICU and usually go to post-acute weaning or surgery. So, like I said, more than 50% of prolonged weaning patients couldn't succeed with the ICU. Majority of those people, 58% of all decontamination patients, usually go to tracheostomy. Benefits of the tracheostomy is patient comfort, reduced sedation, secure airway, etc.
Sorry, just saying the slides are much more than that.
So the timing of the tracheostomy is very controversial. Some studies showing maybe early tracheostomy better ventilator usage or maybe improve mortality, but really doesn't show the clear significance between the timing, early or late. So we really still don't know. And in general, once a patient has tracheostomy, decabulation is the goal for those patients. Of course, we cannot ignore the cost as well. So patients on the ventilator more than 3 weeks, actually the cost is 3 times more than the patients on non-ventilator patients. And then the ventilator patient using more than 1/3 of ICU budget. So now move on causes of breathing failure. So first, I talk about the two main important factors. One is disease important factors that usually lead to the cardiac issues. So through the prone weaning or even regular weaning, we sorting out the reversible factors versus irreversible factors. And once we see reversible factors, we try to fix those issues. The other factor is actually clinician imposed factors. Probably clinician delay in recognizability of patients, or maybe we set up the inappropriate ventilator setting. That results in patients over assistance or maybe under assistance, or could be ventilator inquired on injury, or probably we are not recognizing the asynchronies. So, disease imposed factors, we have so many factors like respiratory, cardiac, so we're gonna talk about those stuff. So first of all, respiratory causes. So once you see a patient on the ventilator, you wanna know the medical history background to set up the goal and expectation. So because the patient is on the ventilator, we as a clinician, we know about any lung issues. So maybe the patient has a COPD, ARDS, pulmonary fibrosis, or maybe the patient has any other organ issues, could be heart issue, brain issue, kidney issue. And we are thinking, are they irreversible factors or reversible factors? The neuromuscular disease or chest wall disorders are usually reversible factors. So that helps us to set up the goal as well. And also we can think of anything else, maybe patient is obese, drug user, psychiatric issues. So those factors help us to set up the goal. Then we can go to details. So ventilation demand. We're looking at the patient, we're looking at the ventilator, and checking how much patient needs support from ventilator. If the patient needs a lot of support from the vent, we think of maybe hypoxic, maybe dead space increase, maybe CO2 production increase, metabolic acidosis, or neuropsychiatric factors. Those are just examples. So you try to find why patient needs support a lot. How about ventilation drive? If the patient is not breathing spontaneously, why is that? So maybe sedation is too much, patient is alkalemia, or maybe he or she has a central nervous system disease, maybe central sleep apnea, or maybe hypoventilation from the EC. Also, you look at airway resistance. So if airway resistance is high, you're looking at maybe artificial airway if it's appropriate size of EP2 or TIP2 size. Or maybe patient has a secretion, a lot of secretion, maybe with a drug. You can do purification, maybe do more open suctioning, or maybe you bronchoscopy. And maybe, bronchospasm, the patient has a bronchospasm too, then you can give continuous bronchodilator. Could be bronchial wall edema, and this patient has maybe ARDS, or maybe have auto peak, so you need to adjust the dynamic. So again, those are just examples, but you can think as much as possible to fix those issues. Respiratory compliance. So two main respiratory compliance issue is chest wall and lung. So if the compliance is low, one chest wall issue could be edema, abdominal pressure increase, pleural effusion, or obese, or maybe lung problem. So patient has autopeep, alveolar filling, pneumonia, interstitial, lung disease, etc. So we can do something. So we can maybe adjust PEEP, do thoracentesis, could do diuretics or suction bronchoscopy. Nowadays, we see it's called CIDW, critical illness associated diaphragmatic weakness. This is a progress decline in diaphragm performance resulting from mechanical ventilation, systemic inflammation, and direct effect on phrenic nerve. So what happens actually is underuse and leads to atrophy or overuse. So patient having excessive inspiratory effort that causes PCD. Patient self incline lung injury.
All right.
This is one of the picture. So showing why patient has a pulmonary edema. It's just a simple explanation. So when patient has a spontaneous breathing trial, usually the intrathoracic pressure change because less positive pressure or maybe negative pressure. So intrathoracic pressure getting lower. That causes increased venous return. When the venous return increase, you see right ventricle preloads, the volume filling at the diastole, and left ventricle preload, those are increased. Also the resistance, so left ventricle afterload to go to the body increase as well. In addition, patient breathing spontaneously, so in general, walk-off breathing increase. As a result, patients have pulmonary edema because not sufficient breathing. And also, this is another example for the cardiac issue, the COPD patients with unstable hemodynamics. So baseline COPD patients have hyperinflation and autopeep in general. So because hyperinflation and autopeep, their intrathoracic pressure is high. That causes venous return low, right ventricle preload low, and cardiac output gets low. Also, the hyperinflation and alveoli over due to the broken alveoli from COPD disease, that is high pulmonary vascular resistance, and that leads to pulmonary hypertension, and their right ventricle doesn't work well. So those are the baseline COPD patients. Then now the patient has a weaning. So on the weaning, patient might have pressure support ventilation or assist control ventilation, and that make autopeep worse, or maybe even the ventilator cannot synchronize with the patient's breathing, and that situation makes their walk breathing worse with hemodynamic compromise. Because of that, we want to really monitor the COPD patient with hemodynamic monitors very closely. So we can maybe use echocardiography or PA catheter, especially checking the right heart function. Also, we can, adjust the ventilator setting, try reduce the inspiratory pressure, tidal volume as much as possible, try auto PEEP to treat auto PEEP to minimize adverse effects on venous return. So those are the example of assessment device for or treatment for cardiac causes. So we use a lot like TTE, EKG, ultrasound, checking BNP, maybe PA catheter. The worst case depends on the situation, use angiography too. And ideally, depends on the device, you want to check those, you want to do those assessment before SBT or during SBT or both. So of course, early identification of high-risk cardiovascular is better to have accurate diagnosis. And in the meantime, while getting the accurate diagnosis, maybe you might want to do tailoring cardiovascular treatment and monitor the patient closely. Those are the examples for treating those causes, cardiac causes, like a systolic left ventricle dysfunction, COPD patients, like consider nitrates, consider calcium channel blockers. Okay. Now moving on, psychological causes. So up to 40% of ventilator patients have psychological causes, unfortunately. Symptoms are anxiety, fear, delirium. So delirium issue is twice as compared to other psychological issues to be difficult to wean. This is a S2K guideline by the German Respiratory 2021 recommendation for management of delirium. Very interesting to me. I mean, I'm a respiratory therapist, but that we really know that make harder for the weaning. Next one is nutritional causes. On mechanical ventilator patient, optimal nutrition strategy is still unclear, but malnutrition exacerbates muscle wasting and delays recovery as we can expect easily. ESP and guidelines for ICU nutrition, we maybe can follow that. And then nutritional optimization is crucial, especially, always we wanna pair with rehab. Next one is metabolic causes. So muscle weakness is caused by low magnesium, potassium, also corticosteroids and hypoglycemia as well. So we can monitor closely not to cause muscle weakness too much. All right. So, we as a clinician, as long as the patient is on the ventilator, we always thinking of how much we increasing the risk just because the patient is on the ventilator. So the patient might have infections such as ventilator-acquired pneumonia, maybe causing the VILI, ventilator-induced lung injury, or patient is having too much sedation, it's not easy to come off the sedation, maybe airway trauma, and this condition getting worse. And then of course, cost is increasing too. So we, as a clinician, aggressively seek and treat reversible causes and make tailored treatment strategy. To do that, ideally, we better have multidisciplinary team, not only physician, nurses, RT. We want PT, OT, speech therapists, dietitian, psychologists, and then put the opinion from each expertise. So I'm going to explain about prolonged weaning guideline. Like I mentioned at the beginning, I don't really see the guidelines a lot. Actually, those 2017 ATS guideline and 2024 AARC guideline is not really for prolonged weaning. I mean, could be any weaning patients. And then the prolonged weaning patients guideline, we found S2K guideline by the German Respiratory Society 2021. Actually, it's over 100 pages. That's a lot of details. I'm just gonna quickly explain ATS 2017 guideline. So the pressure augmentation during SBT. So for the first initial SBT, they recommend to have some pressure support on the PEEP compared to just giving the TPs or CPAP. Or maybe needing having liberation protocol, that established liberation protocol is better compared to non-protocol patients. And then for the patient who has high risk of extubation, but past SBT, they might need a NIV BiPAP after extubation. And then, like RD mobility is recommended, or Catholic test is better for high-risk outriders. So those things are details in the guideline. AARC guideline showing RSBI calculation is not needed. That's kind of interesting for SBT, radius of SBT, and then it's showing SBT can be conducted with or without pressure support ventilation. So not the same as the ATS in 2017. So now talking about prolonged weaning, the German Respiratory Society. So first of all, SBT definition between simple weaning and prolonged weaning is different. Simple weaning, SBT is a diagnostic test for readiness to be extubated. And probably we are very familiar with that. But in prolonged weaning, SBT can be helpful for the process of making decision to diagnose the cause of prolonged weaning. And then, yes, because we having a hard time to wean the patient and then always, cannot wean well, like always, why is that? Why is that? So we have to go through the long process of decision making too. So sufficient unloading of respiratory muscle. So meaning if the patient needs rest, don't let them use respiratory muscle, then just let them rest. That's a recommendation. But also on the other hand, we don't want a patient to rest and not use respiratory muscle because that causes atrophy too. Other things is when patient has a pressure support ventilation, ideal ventilator giving inspiratory and expiratory triggers to adjust their breathing. And so far, the hybrid ventilation like ASV, PAP, NAVA, they are for the prolonged weaning cannot be recommended just because insufficient evidence. So then gradual reduction in assisted ventilation or PSV can be successful for prolonged weaning. And the use of SIV for the prolonged weaning is not recommended. And this mode actually could make the patient work harder. So probably better not use SIV. All right, so almost done. Challenges for the prolonged mechanical ventilator patients. So those patients are medically already complex. They tend to be elderly people, socioeconomically, the isolated, disadvantaged. Probably people don't respect them enough. And they need to rely on ventilator weaning facility or skilled nursing home, or people just go home and using home ventilation. So there are some specialized weaning unit. I don't think it's here in Hawaii though. So after downgrade from ICU, they have specialized weaning unit. Basically, main purpose for that unit is weaning patients. And 60% of the unit can be weaned successfully, and it's cost effective as well. And they recommend to use a protocol. As you see, the chronic facilities, those are the pretty much tracheostomy patients, and then gotta be stable, potential benefit from rehab. And then we have established nurse-patient ratio. Of course, we want to have pulmonary physician maybe once a week or so because we don't have doctors all the time. And then we need respiratory therapists, PT, OT, ST, other occupations. All right, and the home ventilation, discharge home with vent need a lot of support. Could be mechanical ventilator with trach or non-invasive ventilator. Those are the patients usually having beneficial for someone like a neuromuscular disease. And the terminal care, people need to make a decision sometimes. And then maybe first of all, the patient and family face the issue in the hospital. So usually physicians have a communication with them, and then they tell them the prognosis, what's the picture, do they really want it, and depends on the patient and family, different level of understanding. So the communication of physician is really important for them to make a big decision. All right, so final tips. So like I mentioned a couple of times, our job for the prolonged weaning is we try to continuously find the programs and solve the problem if it's reversible. On the other hand, we always aware of ventilator could be harmful on the ventilator patient. So better think of like pressure, rate, try not to have causes bleeding. And then also we better think of sort out the patient really needs, worth to attempt ongoing weaning or not. That's another thing we gotta think of it. Okay, so that's it. Thank you very much. Question or what?
Thank you.